Good afternoon and good evening, ladies and gentlemen, and my dearest colleagues. My name is Yoonjun Kim from Seoul National University Hospital, uh, and I'm the president of the Korean Radioembolization Association. And it is my great pleasure to invite you to participate in the Korean Radioembolization Association International Webinar 2022. In this webinar, under the theme of how to improve care outcome in patients with HCC, experts from USA, Taiwan, Singapore, and Korea will participate in active discussions. Per sessions, Meet the Expert session will be a time for experts to share their experiences and tips on TARE. On second session, many experts will discuss on how to improve TARE outcome by combination treatment, the current evidences, and future directions. I hope you enjoy this webinar. And I regret that Professor Han from NECA could not attend this meeting because of personal situations. And I'd like to introduce the chair of the post sessions, Professor Kwan-Sik Lee from Cha University, Korea, who is hepatologist who have tons of experience in terms of H treatments. And the co-chair will be Yoon-Han Kim from Presbyterian Medical Center, Korea, who introduced TRE Korea in the first time. So please, Dr. Kim and Dr. Lee.
Thank you, Mr. Chairman, for your nice introduction. So, good afternoon, ladies and gentlemen. I'm Yoon-Han Kim, interventional radiologist, and I'm work at Jesus Hospital. Another name is Presbyterian Medical Center in Jeonju, Korea. I'd like to introduce my co-chairperson, Professor Kwan-Sik Lee, hepatologist, Cha University, Seoul, Korea. As we trace our memories of the first TRE performed just 14 years ago in Korea, we feel infinite gratitude and joy as we see the amazing changes we have in the present. Let me start introduction. The first invited speaker of Korea, Korea means the Korean Radioembolization Association International Webinar 2022. Professor Edward Lee, working at the UCLA Medical Center, USA. Today, his topic is my tips in improving TRE outcome in patient with HCC. Professor Lee, please.
Thank you, Chairman. And sorry about my inappropriate TRE. I'm actually on call today. I'm actually still doing a case at 11 p.m. right now here at hospital, so please accept my apology. I'm going to share my screen. Is it being shared? Are you guys able to see it?
Yes.
Okay. Again, well, hello and welcome to today's presentation topic on my tips in improving TARE, transarterial radioembolization outcomes in hepatocellular carcinoma patients. Again, thanks Chairman and the committee for this honorable invitation. My name is Edward Lee. I'm a professor in interventional radiology and liver transplant at UCLA. Hopefully, I can show you anything that you need to know to improve new transarterial radioembolization techniques, mainly the segmentectomy which I'll be discussing today. Here's the disclosure. So I'm going to start with a typical hepatocellular carcinoma case that we deal with every day. Here's the 55-year-old gentleman, alcoholic cirrhosis with the signs of portal hypertension, Child-Pugh score of A, very reasonable. He was found to have a 5.1 centimeter single hepatocellular carcinoma, and he's potentially being consider for liver transplant. At the tumor board, they was recommend to start with the local regional therapy, and they recommend, chemoembolizations, radioembolizations, maybe combination of chemo with the ablation, different option was discussed. Unfortunately, when we talk about when we saw the patient in the clinic and discussed the cost that's associated with it, as you can see it here, compared to chemoembolizations, the radioembolization is about 5-6 times more, and patient opted not to want to do radioembolizations and wanted to do undergo chemotherapy, which we respect that. And here's the depth test that we perform on this patient using a doxorubicin 25 milligram of dose. And it went very well, very smooth, as expected. It was very hypervascular. It was a somewhat selective sort of a chemoembolization we performed. And here's the first 1 month follow imaging, looking very good. They're devascularized. They're not much of a hyper enhancements or any other simple residual tumors that we saw. However, in 3-month follow-up, as you can see, it's questionable whether the test was successful. As you can see, those 2 nodular enhancement on these patients, something that we always deal with, but we always try to improve. Another case to discuss and introduce, again, very similar hepatocellular carcinoma patients. Here's the 55-year-old female who actually is a nurse at one of the hospitals in here. She had Hep B cirrhosis with the mild signs of hypertension, Child-Pugh scope A with the normal LFTs and TBILI at the time of presentation. She was found to have a 2.3 centimeter hepatocellular carcinoma. And unfortunately, she was found to have a small sort of a right portal vein invasion. Again, during the tumor board meeting, we were recommending, since it's a very small branch portal vein sort of invasion, still the radioembolization is a good option. And obviously our oncologists were very, very sort of pro on doing a systemic chemotherapy. Decision was to move forward with the radioembolization first, and follow with the systemic chemo. So again, patient underwent transarterial radioembolization. And here's during the mapping imaging showing the minimal lung shunting. And at the time, this is several years ago actually, that we decided to do right lobar treatment at the time. And we gave 150 gray into the right lobar from, as you can see, catheter being at the right main hepatic artery. Here's the 3-month follow-up actually. No residual, no recurrent disease, AST element LFT completely normal, and complete avascularization of the tumor, which worked great. Unfortunately, 6-month follow-up, we didn't see any tumor or recurrent disease, but we started noticing the patient's liver enzyme wasn't doing well. She started having AST of 1,000, total bilirubin of 7, and now we started questioning maybe this is a late onset of radiation-induced liver disease. That perhaps now patient's going to liver failure. As you can see, even though she had a complete normal large left lobe, her liver wasn't doing it well in overall sense. So again, question always comes up: how can we improve outcomes of these HCC patients, given you're using radioembolizations or any other local regional therapies? So what we have done and what we have moved away from the conventional radioembolization is what we call the TARS or transarterial radiation segmentectomy. Just kind of give you some quick introduction background information. The radiation segmentectomy has been around for about 15 years or so, but really sort of kicked off last 5-6 years. So why are we doing a transarterial radiation segmentectomy? Most important sort of reason is we can spare a lot more normal hepatic tissue, again, having a less hepatotoxicity. Second reason, we're able to get our catheters as selective as possible. And given that, we can deliver a lot higher dose of radiations to focal to the tumor only without, again, the surrounding normal liver, which can cause a complete tissue necrosis with, again, having a better outcome of a tumor response. Another reason is super selective embolization is now being considered as almost an ablative therapy, which again is more of a curative intent than just doing an embolization as what we did in the old conventional radioembolization. Then why would not do radiation segmentectomy? It's not always technically feasible sometimes, and especially anatomically if the tumor is presented in the central area, not so much of sort of a segment, or if it sort of occupies more than a segment, it really is difficult to do segmentectomy. Second reason why we shouldn't do the radiation segmentectomy, it's been known from the surgical colleagues that once patient undergoes segmentectomy with a higher dose, with a lot more inflammations, the patient will have a lot more adhesion during the surgery, which could make it somewhat difficult for them. Lastly, another reason that we should not do radiation segmentectomy is if the tumor have multiple feeding vessels, even though we do cone beam CT to identify all the vessels, sometimes we just not able to select out all the vessels that are feeding the tumor. And again, perhaps maybe then doing low-watt treatment may be better than the segmentectomy. Again, still is the question that needs to be answered. There's several new literature's been out since, this one's the one from 2017, retrospective study. One of my colleagues, Dr. Sid Padia, led this study, single hospital retrospective study, and they showed that curative procedure was not possible for all these patients. So no surgery, no transplant, no ablative therapy, and this patient underwent two groups of treatments, either the radiation embolization or chemoembolizations. 101 patients underwent radioembolizations and 77 patients went chemoembolizations. And their complete response rate of the radiation segmentectomy was 92%. And the complete response rate for chemoembolization was only 70%. And this was statistically significant. More importantly, the same study have shown that local tumor recurrence of the radiation segmentectomy in 2 years only 15%, whereas the chemoembolization was up to 40%. Almost half the patient had some sort of recurrence. Another study that came shortly after, this is Dr. Dave Liu's group in Vancouver who led this study. He compared the radiation segmentectomy compared to the conventional radiation embolizations. And as you can see from the symmetry, they were able to deliver up to 200 plus gray into the tumor using a radiation segmentectomy, whereas when you do conventional radiation embolization, the max is 120 to 140. And also, as we mentioned earlier, much safer for the liver. Dose to the liver was only 70 gray or less, whereas the conventional radiation embolization up to 100 gray could be delivered to normal liver, unfortunately. And their outcomes are also phenomenal. If you look at their overall survival rate in these patients, the patients underwent radiation segmentectomy had over 45 months of a survival, whereas the conventional radiation embolization was only a 22-month comparison, and this was statistically significant. And this also showed interesting sort of side effect profile of the segmentectomy, as I show you here. They're looking at the albumin level, other liver functions, and most importantly, T-bili. As you can see, other sort of a liver function wasn't that much change between either doing a radiation segmentectomy or the conventional radiation embolization. But if you look at the total bilirubin level, with the conventional radiation embolization, there's a lot of variabilities after treating these patients, and it could actually increase the total bilirubin level afterwards. Whereas if you do the segmentectomy, there isn't really much change on any of these lab value, again, showing much safer profile for these procedures. Lastly, this is very, very new, the paper that recently came out this year, led by Dr. Edward Kim in Mount Sinai. And what they have looked at was a single center prospective single arm study. They look at 29 patients underwent transarterial radiation segmentectomy, and their dosimetry have shown this is average median. The dose was up to about 1,000 gray to the tumor, which is again unheard of, but again, they were able to deliver that. And this was translated with a really good clinical outcomes, which I'm going to show here. MRIS's, the tumor response rate was 83% complete response. Overall progression was less than 27%. And overall patient survival was 96%, with the patient mortality was only related to the liver disease, and progression of liver disease not necessarily due to the tumor. Again, have shown absolutely great clinical outcome, again, giving a high dose of radiation to the tumor only. This also show, if you compare the risk of death of the radiation segmentectomy compared to the conventional radiation embolization, the radiation segmentectomy had a 70% or lower risk of death compared to the radiation embolizations. Again, given all this data, I think the radiation segmentectomy may be, and definitely potentially improving the clinical outcome as a patient outcomes overall of the patient undergoing HCC treatments. So here's one of our case. This 30-year-old gentleman unfortunately had a primary biliary cirrhosis with as you can see, signs of portal hypertension. His Child-Pugh score was a B with a T-bilia of a 2.5. Although he was very active and having almost normal life with an ECOG of 0. He was found to have a single 2.2 centimeter ACC. Tumor board recommendation was undergoing transarterial radiation segmentectomy. With the resin Y90, as I know there's a lot of data with the glass Y90 doing a radiation segmentectomy. I have been using sort of a resin Y90 to perform the radiation segmentectomy, and it became feasible and actually definitely improved the outcome using what they call the flex dose. What they have done is in the old legacy, which is on the very right side, the day of a calibration dose, if you were to deliver 1.2 gigabecquerel activities, it's going to require resin of 15 million beads. But now with a 3-day pre-calculated dose or 3-day flex dose, it's reduced to about 60% reduction with number of beads, and you only have to deliver 6.2 million beads, which is a huge number of the reduction, which now there's no concern for embolizations or statics or stasis of the treatment. So again, now the resin could be also be used for the radiation segmentectomy. So here's this same case again. We did the mapping as shown, as you can see it, segment 2 tumor with hypervascularizations. Again, minimum lung shunting. We identified the treatment, and we deliver 230 gray of the resin Y90 specifically to segment 2 only. And here's during the treatment. And as you can see, here's a pre-TARS image. Here's the tumor. Here's 1 month follow-up, complete necrosis of a tumor with avascularization and no vessels that are feeding the tumor. And you can start seeing the shrinkage of segment 2. And here's the 12-month follow again, further reduction of the tumor, no revascularizations, no residual or no recurrent tumor was noted. And this patient now up to about 2 years with, again, no recurrent disease. Second case, again, very unfortunate, 65-year-old gentleman with a hep C cirrhosis with a multiple sign of portal hypertension, non-surgical patient with a Child-Pugh score of A, ECOG of 1. LFT was a normal and decent, but T-bilia was a 2.1 at the time of presentation with a very, very high AFE of 18,000 and found to have a 2 hepatocellular carcinoma. They were both greater than 3 centimeters on segment 4 and segment 8. So again, to move forward, we decided to undergo transarterial radiation segmentectomy. Here's the segment 4 tumor with a 200 grade liver 3-day flex dose with a nice sort of a post-embolization spec. Same thing as the segment 8. It was done at the same day. Again, split dose of a 200 grade each to each tumor, again, with using a 3-day flex dose with resin Y90. Again, showing nice post-radiation embolization spec CT. And here's the follow-ups. As you can see, the very first one, baseline with a tumor with hypervascularizations. AFE was 18,000. 1 month later, complete necrosis of tumor was begun already with an AFE of 7.5. And now 36 months out, again, complete necrosis of tumor, shrinkage of those segments with, again, AFE of complete normal right now, and patients doing very well, and patients not needing a transplant at this point. So in summary, I put little cartoon sort of illustrations here. As you know, the evolution of a human, and as you know this very popular graphics, but I changed that to evolution of hepatocellular carcinoma treatment. So I think, as we know, very primitive, the ones that we always done in the past was a systemic chemo. But I think we have that improved to local regional therapy with the chemoembolization and ablative therapy. But at that point, I think we went even beyond and improved to transarterial radioembolization. But that's further refined and improved to what I call the transarterial radiation segmentectomy, which I think really will truly help these patients and their outcomes. So again, transarterial radiation segmentectomy is definitely better hepatocellular carcinoma treatment compared to TACE or the conventional radiation embolization. And as I mentioned in a couple of studies, it has much better and safer profile. And still, there's a question of, is it harder, is it better, is more dose always better? Again, it's a question to be answered, but that's something that we always need to be considered. But as you can see, some of the studies, higher doses, 200 grade, 400 grade, even up to 1,000 gray of radiation to the tumor has been very effectively treating these tumors and better outcomes. As I mentioned earlier, resin Y90 transarterial radiation segmentectomy is definitely possible. And due to the new pre-calc or flex dose, it has improved and is as acceptable mean of doing radiation segmentectomy. Currently, we don't have much of a guidelines and standardizations. I think that's very important globally. And also more research data and trials are definitely needed at this point. With that, thanks for your attention, and I'll conclude my presentation. Thank you very much.
Thank you very much for your excellent presentation. So at this moment, we have Q&A session for about this lecture. At this moment, we don't have any question through the Zoom. So I have to ask you. And radioembolization, especially radiation segmentectomy, is the most impactful when treating areas that are not readily accessible by percutaneous ablation, including hepatic dome, Hodet lobe, hilum, and the locations adjacent to vessels and the bile duct. So many advantages through the radiation segmentectomy to compare the percutaneous ablation therapy. How about in the actual your experience? What is the best advantage to use to perform radiation segmentectomy?
So thank you, Professor Kim. I think I was believed to when I was doing the radiation embolization for now, over almost 15 years now, I felt that, always just appropriate dosimetry is important, not necessarily a hot or higher dose is important. But again, I'm starting to change, questioning that as well as I'm doing more practice right now. I think perhaps, having this hotter, more focused, higher dose, again, as mentioned, 200, 400, 1,000 gray, the fact that we are able to deliver that to the tumor, I think this is very important for the outcomes of this tumor response. Again, I think that's the most important thing why radiation segmentectomy has been, for the place for us to replace our traditional radiation embolization. I think I have a question in the chat box. One of the question was, why do I think the TARS is safer than the conventional tear? Again, I think because of these, patients who's having the ACCs, I think their liver functions are vulnerable. I think they're, again, they're end-stage liver disease that could be very easily tip off from the decompensated liver, disease, because again, they've been going on for a long time. So any type of insult to the liver could really make them, from the normal liver to really sort of a failing liver with any, again, insults. So having said that, when we used to do the lobar treatments, I think we're, affecting a lot bigger area of the liver, which could be potentially translate to potential more insult to the liver. But when with the radiation segmentectomy, we really truly try to focus and try to select as little space as possible, super selective, into the area of a tumor. And again, I think that's why it spares the normal or other rest of the liver. And hence there's why potentially, again, not completely proven. I think there's this hint and suggestion that the TARS is probably safer than the conventional tear. The last question I also have is, what is the minimal observed dose that you recommend for tears? I think, again, when you do conventional radiation embolization, we aim for about 120 gray to the tumor. But I think when we do radiation segmentectomy, I think we're looking at probably above that, like 140. But usually I aim for about 150 to 200 as sort of a minimal the tumor dose that I use for. Any other questions?
Technically, I'd like to ask you, and
Yes.
is it without any technician study? And actually, we are using in the small amount of radio isotope to perform radiation segmentectomy. So
Mhm.
we can, without technician study, is it possible to at present in your application? Basically, we have to do in the nuclear medicine study, but is it possible to in your future in the prompt treatment for the small lesions? Like, yeah.
I mean, I think it's, when we do the mapping and you're using a technetium study, of course, we're looking for the dosimetries and, where we're treating these tumors and how much of delivery to the area. But I think we also are looking at, safety profiles. I mean, are we having any collaterals that we're going to some other organs, pancreas, the stomach, lung? And I think all those are still, even though we're doing a radiation segmentectomy, I don't think we have a standardized technique, which is a completely safe, that we still think needs to do the mapping procedure in order for us to completely sort of, be safe for the radiation segmentectomy still. So I'm not sure if there's any other alternative method. I know there are a couple of investigators are working on sort of a lot easier or even same day sort of mapping procedure. But again, I'm not sure if that in the near future that will be standardized.
Okay.
There's a question. Oh, yeah, there's a question asking what made the LFT abnormalities in my second introductory case. Again, I think, as I mentioned earlier, patient presented with a complete normal LFT, and only thing that I could think of was, again, patient maybe was on the verge of becoming decompensated, liver disease process. And when we did an entire right lobar, which was, I believe, about 60% of his liver, her liver, I think that's what may have tipped him off into the, LFT abnormalities afterwards. She actually did not recover her liver injury, what we think is radiation-induced liver disease, the liver injury, and she ended up had to undergo liver transplant because she was expedited with the exceptional point. So again, I don't think we have, even though we do have a good sense of what sort of a LFT that was required to undergo radiation embolization, I think there's still certain subset of patients that we just don't know how they will react after when they're exposed to radiation.
Okay, so thank you for your nice answers.
Thank you.
Thank you very much again. And we move to second presentation. Will be presented Dr. Ko Han Lin. He is a nuclear medicine people, Taipei Veterans General Hospital, Taipei, Taiwan. Dr. Lin's topic is Y90 dosimetry from MIRD model to multi-compartment model. Dr. Lin, please.
Thank you, Chairman. Anyone hear my voice, or can you see my slides?
Yes.
Okay. So, okay, thank you, Chairman, and thank you for the invitation from Korean Radioembolization Association. I'm Dr. Ko Han Lin from Taipei, and my topic is moving from MERD model to multi-compartment model to do the Y90 dosimetry. So Y90 radioembolization is a local regional therapy using intra-arterial delivery of radio-labeled microspheres. So therefore, optimal pretreatment planning is one of the key issues for a successful radioembolization treatment to guide the Y90 microspheres to the tumor. So that includes an optimal angiographic technique and planning, and optimal TCMA delivery and mapping, and then we may need to modify the procedure based on these findings, including the angiography, angio-CT, combine CT, and the TCMA spec CT. And the other issue for the Y90 treatment is the dose. So based on the TCMA mapping, several dosimetric models were developed, including 2, 3, and multi-compartment models. The traditional 2-compartment models include the MERD model for the glass Y90 and BSA model for resin Y90. They calculate the lung and liver distribution called the lung shunt fraction based on the TCMA simulation. and the lung shunt fraction is quite essential for the pre-treatment dosimetry to calculate the lung dose in order to prevent the radiation pneumonitis. Another benefit for the two-compartment model, including the MERD and the BSA model, they are very simple to use. So the dosimetry is quite simple to calculate using the two-compartment models. However, the two-compartment models assume a homogeneous distribution of Y90 in the target liver and tumor. So if we use the two-compartment model and we can only have a mean dose to the target liver without knowing the dose to the tumor and the normal liver, because the tumor dose and normal liver dose were not calculated using the two-compartment model. So if we use a glass using the MERD model, we have to set a desired dose. The range could be from 80 to 400 gray, and the desired dose may be adjusted based on the tumor vascularity, treated event volume, and liver function, lung dose, or the performance status of the patient. However, the limitation of MERD model comes from that it lacks tumor vascularity quantification because we do not calculate the tumor to normal liver ratio if we use the MERD model. So we won't have the tumor dose, won't have the normal liver dose. And so if we have a low tumor burden or we have a hypovascular tumor, we may give too many doses to the normal liver. So maybe the normal liver will be damaged. Similar limitation was noted in recent BSA model because the BSA model is mainly based on the patient height and weight. So we can find that almost all the activity calculated by BSA model, the activity always within 1 to 3 gigabecquerel. So sometimes we may have underestimate the activity if we have a large tumor volume or a large liver volume. Sometimes we may overestimate the activity if we have a small tumor volume or a small size of liver. And also, the BSA model did not take the tumor vascularity into consideration. So sometimes if we have a hypovascular tumor, we may give too many particles to the normal liver because the tumor was hypovascular. For example, if we have a very large SCC, this is a very large SCC occupied 45% of liver, and based on the BSA model, we can only give 2 gigabecquerel to the tumor, and the tumor dose will be only 55 gray. But based on the partition model, we may give twice dose to the tumor. We can calculate by partition model, and we need 4 gigabecquerel and reach the tumor dose 109 gray. So if we have a very large tumor, the BSA model will underestimate the dose. And previously, we have 2 trials of using recent spheres and compare with the sorafenib, that's Cervinib and Sarah study. One is in Asia and another is in France. And these 2, unfortunately, these 2 studies, the overall survival benefit was not found when we use the recent sphere to treat the HCC. But unfortunately, at that time, some institutes, they use only BSA model for the recent planning. So the treatment might not be very optimal when we conduct these 2 trials. So a further analysis published in Radiology in 2020, and they take the MAA distribution and tumor absorbed dose into consideration. We can see almost nearly 50% of patients are pre-treatment planning using TCMA. The result was suboptimal. The suboptimal means that the MA only covers partial tumor, and sometimes we may have nearly 30% the result was not optimal. That means the tumor was over here and the TCMA was totally mismatched with the tumor. So that means in this study, Sarah study, almost 50% of treated cases may have under treatment based on TCMA images. So if we take subgroups of patients with optimal TCMA distribution and tumor absorbed dose for analysis, we will see if we have an optimal distribution and higher dose, longest survival and the best disease control rate were observed when we consider the distribution of MA or 190 and the tumor dose more than 100, and the survival and disease control rate was very good. So lessons we can learn from the third study is that third is a local regional therapy. So non-target delivery of 190 may result in poor outcome. And also the tumor dose is important. After we deliver the 190 exactly, we need to do a precise tumor dose calculation, and we should give higher dose to the tumor and may result in a good outcome. So in order to have a more precise and personalized dosimetry, the recent 190 now suggests a partition model. The partition model uses a 3-component model, calculate the lung, normal liver, and the tumor. And the most important is the TN ratio, to use the TCMA simulation to calculate the TN ratio, and we can calculate the dose to normal liver and to the tumor. And for the glass microsphere, now they propose the multi-component model, also using the TN ratio to calculate the tumor and normal liver dose. I would say this is the glass version of partition model. They calculate the TN ratio also. So one of the main difference between the recent partition model and the glass multi-component is the target dose. The recent suggests 120 gray for HCC for the target tumor dose, and for the glass 190, they suggest 205 gray for the HCC of the target tumor dose. Furthermore, the glass, the multi-component model, emphasizes on using a software assistance to do multiple segment calculation, including multiple segment treatment or multiple tumor dose calculation. So that's why called a multi-compartment model. So recent 2 studies of glass 190 emphasize the tumor dose and the relation of tumor response using multi-compartment model. So the dose does matter. The first one is the target study, a retrospective multi-center investigation for HCC. From this study, they found the responder have higher tumor dose compared with non-responder, and more complete response was observed when the patient received more than 300 gray tumor dose. And mean overall survival was significantly longer in patients with received tumor dose more than 300. Another study is DOSIsphere 01 trial, a randomized randomized multi-center phase 2 trial for HCC larger than 77 centimeters without extrahepatic disease. And 56 patients were divided into a standard dose group using merge model to reach mean dose of 120 gray, and another 28 patients using a personalized dosimetry using a software to do multi-component model dose calculation and to reach the tumor dose more than 205 gray. So the mean tumor dose in the personalized group was significantly higher, and also the overall survival was significantly longer when we use the personalized dose group. That means using the multi-component model, and the overall response rate was significantly higher when we use the multi-component model to do the treatment. So we can learn from these studies that the key elements for a successful third treatment is one, not only requires an optimal pre-treatment planning, but also a precise and personalized tumor dose calculation using the TCMA simulation. And in this way, we can give higher tumor dose to achieve better response. And furthermore, we may lower the normal liver dose according to the TN ratio, and maybe in this situation, we can reduce the possibility of radiation-induced liver disease. Furthermore, not only the pre-treatment TCMA scanning, we can use this dose calculation, but also we need to calculate the post-treatment imaging for the dosimetry, because the TCMA mapping is the simulating scan. The distribution of MAA could be manipulated. For example, this case, we inject the TCMA from the proximal left hepatic artery. Unfortunately, the TCMA goes to the normal liver, and the T ratio is less than 1. So when we did the treatment, we did the supersegregation to inject the 190, and then we can see on the post-treatment 190 PET-CT show that 190 goes to the tumor instead of the normal liver. So the post-treatment scanning is very important because this is a validation scan. We can see the actual distribution of the 190 particles, and also we can use this actual distribution of 190 particles and do the real dosimetry after we did the treatment. But for the post-treatment imaging, especially for the post-treatment dosimetry, another big issue is the software. Because for the multi-compartment model, another big issue is the software. Personally, I had involved in 190 planning more than 14 years in Taiwan. It's quite difficult for me to calculate the pre and post 190 dose in previous decades, especially the post-treatment 190 dose. Actually, almost all institutes in Taiwan have the same problem, that we do not have a proper software to do the precise dose calculation. If we want to use the software to do the multi-compartment model, it should have some functions like we have to do the tumor and liver volume segmentation, and also we need to convert the MAA or Y90 counts into dose, and then we can do the voxel-based dosimetry and transform the dosimetry into dose model histogram. But now we will have several commercial right software to choose, including the Rapid Sphere, Planet Dose, SurePlan from MIM, and Simplicity from Mirada. They can do the multi-compartment model dose calculation. So for the Galaxy 190, the Simplicity is promoted just as its name, a very simple tool to do the multi-compartment model for 190 treatment. So the Simplicity is quite easy to, I think it's quite easy to use, and it is also a one-stop shop dosimetry tool. We can import the images and to do the long-shunt fraction calculation, and we can use it to do the CT, MAA, or even MRI registration to do the to register these images together, and then we can do the tumor and normal liver segmentation, and also do multiple tumor segmentation, and then we can give the 190 activity, and we can get a dose of the tumor, of the normal liver, and also the lung, and then we will have a dose volume histogram from the software. We will know the dose distribution in the tumor and in the normal liver. For example, if we use the merged model or partition model to calculate the dose, we will only have a average dose when we use a merged model. For example, in this case, we want to treat a large tumor in the right lobe, and we want to give, because the lung shunt fraction is quite high and the tumor was large, so the lung dose will limit the activity we give. So based on merged model, we give the average of 82 gray to treat the tumor, or we can use the resin, the partition model, and the tumor dose will be 120, and the normal liver dose around 45. But we can use the Simplicity to do the multi-compartment model calculation, and based on the software, the MA result, you can see the tumor dose will be, if we give 2.5 gigabecquerel, the tumor dose will be around 140. And we can also import the post-treatment 190 PET imaging into the software, and we will have the result, 3.5 gigabecquerel 190, and we can reach a mean tumor dose of 160. And also we can check about the V100. That means 64% of tumor receive more than 100 gray. So with the software, we will know not only the mean dose to normal liver, mean dose to the tumor, but also we will know the distribution of dose inside the tumor and inside the normal liver. So now, if possible, we use almost every cases using the multi-compartment model unless the tumor segmentation is difficult. So that means almost all HCC cases, almost all metformin cholangiocarcinoma, or even hypervascular or segmentable metastatic disease, especially the NET, we can use the multi-compartment model, the software, to calculate the dose. But sometimes we may have some problems of using software to calculate the dose, because sometimes we may have tumor without boundary or multiple small tumors, or sometimes we will have big mistration between MA and CTs. In this situation, maybe the multi-compartment model will have some limitation. Just like that, this case, I think it's quite easy to use a merged model to do the calculation for the radiation segmented doping instead of the multi-compartment model calculation. And for these multiple small tumors, it's quite difficult to do tumor segmentation. In this situation, the software will do little help to do the multi-compartment model calculation, because we cannot draw exact the tumor boundary and the tumor ROI in this case. So recently we had an observational study conducted by Dr. Ren-Chuan Li, and we include 30 patients treated with GLAS 190, and we want to check about the pre-treatment TCMA spexity and the post-190 PET MRI dosimetry, and also compare with the tumor dose and the response rate. The pre-treatment TCMA showed the mean lung shunt fraction were 7.6, and the mean activity given was 3 gigabecquerel, and the mean tumor volume was about 360. So we can see if we compare with the pre-treatment TCMA spexity and the post-treatment 190 PET MRI, we can see the TN ratio on post-treatment 190 PET was significantly higher, and also the tumor dose, while we lower the normal liver dose. That's because we adjust the injection of 190 if we saw the MA result was suboptimal. So we would change it to super selection injection of 190, or avoid branches with high MA shunt if we do not see any obvious tumors inside this area. And then, so that's why we will have a better result on post-treatment 190 PET MRI. The TN ratio and the tumor dose was higher, and we successfully lower the normal liver dose. For example, in this case, we can see a very large tumor in the posterior segment of liver, and some part of the tumor was supplied by inferior phrenic artery. And after we inject the TCMA, we can see the MA goes to the anterior segment, and most of the TCMA goes to the normal liver. So this on pre-treatment MA spexity, the TN ratio was less than 1. But after we do the adjusted injection of 190, we can see that this is the post-treatment 190 PET MRI. We can see the microsphere went to the tumor very well without apparent shunt in the anterior segment. Then, so the TN ratio changed from 0.5 to more than 3 after we adjust the injection. So 28 patients were eligible for the response rate assessment, including 22 HCC, 2 cholangiocarcinoma, 3 NET, and 1 metastatic colorectal cancer. And we have 20 responders. We can see the pre-treatment MA dose and the post-treatment 190 dose was significantly higher in responders, and also the 190 PET-TN ratio. And the cutoff, that means if we give more than 158 grade C on the MA PET, so the response was good. And if we saw the tumor response dose more than 196, and we will have a better response. And 22 HCC patients were eligible for the response rate evaluation, including 16 responders and 6 non-responders. Also, we can see the pre-treatment MA dose and post-190 dose was getting higher in responders. So if we give more than 170 grade to the tumor, and we will have a better response. So this is an example of very large SCC, more than 18 centimeter in the right lobe. And the dose was limited by the lung because the tumor was very large. So we want to give 7.3 gigabecquerel to the tumor and to reach the average dose of 150, because the lung dose was 30 if we give 7.3 gigabecquerel. And then we injected 1 15 gigabecquerel week 1 and 1 15 gigabecquerel week 2, glass 190 to treat the tumor. And based on the multi-component model, we can see the mean tumor dose calculated with the post-treatment 190 imaging. The average dose for the tumor was 177 grade, and more than 70% of tumor received more than 100 grade. That's V100 tumor, more than 70. So the result should be very good. And this patient received, the images after 3 months, we can see apparently necrosis inside the tumor. And this patient received right lobectomy 5 months after the 190 treatment. And the tumor, most were necrosis, and only 50.5% of tumor was viable. So this is a very successful treatment of the 190 treatment. The tumor was downstage to resection, and this patient is quite well right now. So the conclusion, the dose does matter. So we need to do the personalized dosimetry. It provides a more accurate dosimetry for 190, and we can give, if we can give a higher tumor dose, and we'll have a better treatment response. And also the post-treatment imaging and dosimetry is quite important, essential, because we will know the real dosimetry of the 190. And we can use a multi-component dosimetry using software, because this is a one-stop shop tool for the treatment planning and dosimetry calculation. And this is a personalized and precise dosimetry for 190 treatment. And further, we may need to insert this personalized dosimetry and software-assisted dosimetry into our 190 planning workflow, and we will have a better dose response correlation, and we can do further analysis of the 190 treatment and survival or the treatment response. Thank you for your attention.
Thank you very much for your excellent and informative lecture, Dr. Lin. And at this moment, we have a little some behind the schedule. I just first 2 June questions. What is the key difference between standard dosimetry and personalized dosimetry? And second thing is, does your hospital administration or any insurance system reimburse application of any dosimetry software? So you can answer.
Okay, I can answer the second question first. Now we don't, the insurance won't cover this. This is the post-treatment dosimetry using multi-component is our daily practice, including in our daily practice of 190. Yeah. Sorry for the first question. I didn't hear that. Sorry, the first question. The first one. Sorry.
it's just simple and the standard dosimetry and the personalized dosimetry. What is the key difference?
Okay. The simple dosimetry using merge model, we only calculate an average dose. So we won't know the tumor dose and the normal interval dose. So if we use a multi-component model, we can know exactly the tumor dose and the normal liver dose. So if we can adjust the dose based on the TCMA TN ratio. Sometimes if we have a very high TN ratio, we can give more dose to the tumor. And sometimes if we see the TN ratio is not high, maybe we should lower the dose. But of course, the result will be suboptimal. Yeah.
Okay, so at this moment that we have behind the schedule. So I think in the more comparable questions to you, so let you know and some answer to each participant via email. Okay, so
Okay.
we'll
Of course.
distribute in your email. Okay.
Of
Thank you
course.
very
And
much.
all. Okay. Thank you.
Thank you very much for your
Thank
nice lecture. So I
Thank you.
move to the next presentation to Bayer that Professor Lee.
Okay, last topic of this session is also my tips in improving TARE outcome in patient with HCC, which will be presented by Professor Dong-Ho Hyun. He's a associate professor of interventional radiology session, Samsung Medical Center of Sungkyunkwan University, Seoul, Korea. Professor Hyun, please.
Thank you for your introduction, Mr. Chairperson. My topic is similar to the first presentation. This graph shows the experience level according to the timeline. Maybe anyone who performs radioembolization would be somewhere along the line of this graph. Maybe I think I'm at here, but I need to jump up for radioembolization to improve my treatment outcomes. The most important part is feedback-based building up period. Positive feedback is very important. Negative feedback would occur during the procedure or treatment course because of the poor indication or poor technical aspect. The procedure of radioembolization would be break down into the 5 sub stages. The first stage is pre-intervention workup, and next one is tumor targeting and dosimetry, and next one is intervention. And follow-up period would be like this: post-treatment imaging and complications. As you can see, this table, I think the tumor targeting and dosimetry is very important, more than important than the pre-intervention workup or the other procedure steps. However, from my experience, I think the dedicated MDT, multidisciplinary discussion, or post-treatment imaging is the hard to overcome in Korea. The first step is tumor targeting and dosimetry. Technetium MAS scan, the planar scan is mandatory to check up the lung shunt fraction. In this patient, HCC embeds into the middle hepatic vein, and there on angiograms there is a multiple aneurysmal changes within the tumor vessels. The lung shunt fraction is over 60%. I think radioembolization is not possible because the tumor thrombus is embedded nearly the IVC. So the supplementary measures to occlude the hepatic vein is not possible in this patient. In my opinion, conventional TACE is also risky because large amount of lipiodol to be injected will be shunted to the lungs. However, the planar scan is not enough. because it is a summation of the 3D images. So we don't know the exact distribution of the technetium MAA within the tumor. In this patient, a 5.7 centimeter tumor between the middle and right hepatic vein. The planar scan is like this. Fortunately, the SPECT CT scan shows the homogeneous uptake of the technetium within the tumor. This patient has HCC with VP4 invasion. Fortunately, also the technetium is homogeneously uptake in the tumor thrombosis. However, in this patient, the technetium scan shows the cold spot in the tumor thrombosis compared to the parenchymal tumor hot uptake. This findings shows that we need more additional extra treatment for tumor thrombosis like this. Radioembolization for parenchymal tumors plus RT or proton therapy for tumor thrombosis. However, technetium scan is not perfect. There are some drawbacks with dosimetry based on the technetium scan. This graph shows the discrepancy between the technetium scan and the post-treatment scan. The red graph shows the tumor dose. There are less poor correlation between those two scans. Especially glass microspheres shows the poor correlation. The confidence interval of the tumor dose is quite wide. And you can see the almost two-fold or four-fold discrepancy between the technetium and post-treatment scan on tumor dose. So there is an attempt to use the Scout Y90 spheres to assess the tumor distribution and long shunt. From this study, they concluded that Scout Y90 is way better to predict the long shunt or tumor dose, especially for non-segmental therapies. This scheme may come from the Holium radioembolization. Holium Scout scan is quite incredible. This shows the personalized dosimetry and standard dosimetry comparison. IFU is not recommended for personalized dosimetry. However, in many clinical situations, we use personalized dosimetry because the tumor dose, tumor response, pathology response is way better than standard dosimetry. So the safety issue is very important for patients. However, the personalized and standard dosimetry shows the acceptable patient safety. The purpose is different between them. Curative intent is used for personalized dosimetry. So at the beginning of my procedure, my choice was standard dosimetry recommended by the provider. However, these days, my choice is personalized dosimetry. Personalized dosimetry was proved by this study, dosisphere study. Overall survival, progression-free survival is better with personalized dosimetry. In this study, 205 gray over is recommended for the treatment. However, safety profile is, as I mentioned before, is similar between them. In Korea, Dr. Kim reported this report, this study. He used the higher dose, so-called standard dosimetry, similar with. They reported that the boosted dose, higher dose of tumor dose is favorable tumor response. But I don't know why the biliary complications occurs more frequently with higher dose tumor dose. Next step is intervention. When you perform procedure, make a kind of procedure suite for delivery of entire activity as planned. I always make this kind of procedure step when and where to infuse the Y90. To avoid the complications is very important. This patient shows 4.6 centimeter HCC in the left liver. However, planar scan shows the eccentric or irregular uptake along the aorta or the esophagus. SPECT shows the uptake of the esophagus. This might be from this branch, the accessory gastric artery. So careful analysis of the angiograph is very important to prevent non-target embolization. During the procedure, the branch was embolized with coils. The post-Y90 scan shows the disappearance of the eccentric uptake. Efficient control is not easy. Some authors or some researchers recommended that use of systemic therapy or conventional TACE or the other treatment modalities, external beam radiation therapy. From an interventional radiology point of view, occlusion balloon catheter would be one of the solutions to decrease the AP shunt. In this patient, the angiogram with balloon deflated shows the AP shunt, but inflated, the shunt has decreased. So BTACE, maybe you heard of BTACE. However, B-tear is not that familiar. However, the distribution of the Y90 is more intense within the tumor and with B-tear. So I think from a particular distribution point of view, we need more measures to distribute the particle evenly within the tumor. Patient selection is the most important part. A recent update shows the radioembolization is located in the very early or early stage HCCs. This based on the legacy study, but legacy study has some insight into the treatment of the radioembolization. If you look at the table of baseline and Y90 treatment characteristics, the tumors are less than 5 centimeters mostly, and the treatment approach is the radiation segmentectomy. And also the number of wires used is less than 2 wires over 95% of the patients. The observed dose is quite high, way higher than the standard dosimetry. The time to progression-free survival, overall survival is better in this study. Tumor biology is also important, but we don't know any consistent measures to predict the tumor biology. In this patient, 7 centimeter HCCs with some satellite nodules in the right lobe of the liver segment 8. Angiogram shows like this, huge mass with some nodules, and lung shunt fraction is not that high. So we approach this patient with radiation segmentectomy fashion. So, however, the tumor markers rebound after 1 month, quite high. MRI shows the Y90 is fully distributed in the segment 8. However, the tumor recurrence was observed in the same segment. And also there was tumor thrombosis, new tumor thrombosis. So we performed tests like this. This is the same distribution of the Y90 territory in the liver. So tumor biology is also need to be considered when you select a patient. Perfusion. I made this term. Perfusion means the perfused area of the Y90 or contrast materials. This patient shows the 4.7 centimeter HCC. Specs show hot uptake, and automated feeder detection program shows the one feeder from the right hepatic artery. So this can be defined as one perfusion. Like this, middle hepatic vein and segment 4 hepatic artery, segment 8 hepatic artery, one perfusion. Perfusion is associated with the tumor recurrence after the treatment. This kind of perfusion and the partial coverage and tumor-only coverage. The group A shows better local tumor control compared to the B or C. I think this kind of concept can be applied to the radioembolization. This patient shows small tumor in segment 8 or 4. Angiogram shows 2 feeders from segment 8 hepatic artery, segment 4 hepatic artery. SPECT scan with only right hepatic artery shows the partial uptake of the tumor. So the summary is segment 8 and segment 4 feeders. So the treatment was performed at both hepatic arteries like this. Tumor coverage was complete. However, the sacrificed area of the non-tumor liver was larger than the one perfusion tumor. So when you plan the radioembolization, especially the patient liver function is vulnerable, I think the perfusion concept should be implemented in your decision-making procedure. Multidisciplinary clinic is quite helpful for me and for me to decide the pace or radioembolization. The other treatment modalities should be considered before when you perform radioembolization. The hard issue is the combination treatment with tyrosine kinase inhibitor or immune checkpoint inhibitors, systemic chemotherapy. I think the combination treatment is quite helpful for some kind of patient. Still, we have some ongoing trials, so we need to check the outcomes of the combination treatment studies. In summary, spexity is not perfect. However, we have to do the SPECT scan, and personalized dosimetry is very effective than standard dosimetry. And try to achieve even particle distribution, we need to do some extra measures, such as balloon or dominant flow check. Careful analysis of angiograms and use of appropriate procedures is needed to avoid complications. Patient selection is the most important part. Tumor biology and perfusion concept is also uh, uh, considered. MDT discussion would be the one of the solutions. I think please participate in the multidisciplinary team. The combination treatment is coming. Keep up with the result of the new studies. Thank you for your attention.
Thank you for the nice presentation. We have a limited time, so we can discuss about only one question. What do you think about the risk factor for the biliary complications?
Thank you for your question. I don't have the exact answers for that, but I think the higher dose and the selective radioembolization would be the risk factors for biliary complications. The answers for second question, I don't have experience TARE on the nodular cholangiocarcinoma. Thank you.
Is TARE still effective in advanced HCC with portal vein thrombosis?
In the early stage of the radioembolization, we all hope that it would be effective. However, I think advanced stage HCC with portal tumor thrombosis more than lobar branch is not effective with radioembolization. I think so. However, some studies still reported that radioembolization is effective, but I don't think that.
Okay. Okay. Thank you. Okay. Thank you for all the professor and attendee. I hope this session is meaningful for all attendee. And we are going to close this session. Thank you, everyone.
Thank you very much.
So now we have about 10 minutes short break and we begin at 5:30 in Korean time, 4:30 in Thailand and Singapore. Thank you. We see you at 30.
Good afternoon, my colleagues. My name is Yunjun Kim from Seoul National University, and I will be chair of this session with Dr. Shin from Samsung Medical Centers. And the topic of this session is improving tear outcome by combination treatment, current evidences, and future directions. Everybody knows that this is system IO drug era, but however, the efficacy is still not satisfactory, and we will find the combination of local regional treatment with systemic treatment. And first speaker will be introduced by Dr. Shin, and second and third topic will be introduced by me. Dr. Shin, please.
The first speaker is Professor Jin-Si Sung from Yonsei Medical School. She is a radiation oncologist, is world leader in this field. So we are very happy to have her to join in this webinar. And her topic for today is optimal selection and incorporation of radiotherapy for hepatocellular carcinoma, TRE, and EBRT. Dr. Song, please.
Thank you, Professor Shin, for a very nice introduction. And I'm very pleased to join this important session discussing how to improve TRE outcome in hepatocellular carcinoma patients. I was given to talk about under the title of TRE with the EBRT combination. So let me start my slide. So let me begin with my the slide with a patient example showing some unsatisfactory tear result. This patient present the solitary tumor, the big tumor in right lobe, but there's no intrahepatic mets, there's no extrahepatic metastasis. So the shunting study was okay. So tear has been performed, and after tear, well, although there's some necrotic area in the core, but still there's the viable tumor persists in the periphery of the tumor. And then there's occurrence of intrahepatic mets and also occurrence of lymph node mets, and the tumor marker increased. So this is the unsatisfactory example of the tear result. The other patient showing a rather small tumor, the well-capsulated tumor. And then we did a tear, and after tear, the tumor markers decreased. Actually, this patient underwent 2 sessions of tear. And then at this time, the radiologist interpreted this imaging as a complete necrosis of tumor. And this one has been disappeared soon. Then with more follow-up, there's some viable tumor appearing in the border area of tumor capture. And then tumor markers, PIVCA2, raised from 64 to 88. So even small tumor, we can see some failure on the part of the tumor. So why is that happen? So we need to go back to the basic notion. So first, the basics in radiotherapy. Radiotherapy can be classified into 2 types. First, external beam radiotherapy, in other words, teletherapy. In this case, a source, the deliver radiation beam far away from source to the target. Usually, this is a 100 centimeter, and this kind of radiotherapy is done by a linear accelerator. And in contrast, internal radiotherapy, in other words, brachytherapy, we use a sealed source radioisotope. And one typical example is that when patient with a lung cancer showing a bronchial obstruction, then radioisotope material can be implanted or injected through a bronchoscope for that region. So for external beam radiotherapy, usually photon X-ray is very popularly used. And these days, there's more interesting interest for particle use, like proton beam or carbon ion. For internal radiotherapy, mostly gamma ray is used for internal radiotherapy. For example, uterine cervical cancer and or the lung cancer or other types of the brachytherapy. But in liver cancer, we use a beta ray in the yttrium-90 tear treatment. So let's remind of what we've learned through middle school. So you may remember that in there's 3 types of radiation beams in case of radiation decay. So from the unstable material atom, then there's alpha radiation consists of 2 protons and 2 neutrons. But this is a very weak and a very short distance travel, so it's not used in clinical radiotherapy anymore. And then this is a beta radiation, consists of a high energy electron. This is also particle beam. And another one is the gamma radiation. This is not particle. This is just a high energy electromagnetic photon. So to compare the strength, beta ray electron beam can easily be blocked by thin aluminum foil. However, gamma ray or artificially made X-ray has a more deep penetration depth, though the thick lead is needed to block its passage through the tissue. So actually in clinical radiotherapy, the room where radiotherapy machine is installed is made of the 6 walls, all consist of 1 meter thick concrete. And also this primary beam direction is even double fold. The very thick 2 meter thickness concrete wall is made. So when there's some nuclear exposure, you need to run out to this the radiation room. So external beam radiotherapy evolved very fastly. In the past, it was a very simple 2-dimensional, but now we use image guided RT or intensive modulation RT. It's a very precise coverage of tumor, then avoiding normal tissue damage. But now, external beam radiotherapy has a very critical weakness. So when tumors located in this area, we can deliver very high dose very safely. However, if tumors is in the edge of the liver like this, then it is adjacent to the radiosensitive organ. It's very difficult to deliver high dose radiation concerning radiosensitive organ damage. So one example is a tumor located in this port hepatis, and this tumor abutting antrum of the stomach and the duodenal cap. So for those areas, we can deliver high dose radiation. In contrast, internal radiotherapy, tear in case of ACC, through vascular access, the radioactive source is delivered and the radiation is delivered at very high dose only to the tumor, so it looks very ideal. However, we need to think about 2 facts in consideration of the successful the treatment using radiotherapy, either external or internal. Fact number 1, tumor size. This notion has been well studied with numerous papers, particularly regarding radiofrequency ablation. So when tumor size are smaller than 2 centimeters, there's a chance of microsatellite tumor, 3% within the 5 millimeter margin. Then with a less than 3 centimeter ACC, then this instance goes up to 19%. Now, when tumor is larger than 3 centimeter, we need a margin 1 centimeter or more. So think about the tumors you usually apply tear. Usually tumor size less at the more than larger than 3 centimeter. Then for external beam radiotherapy, the principle is that we define gross tumor volume determined by the imaging study. Then concerning for microscopic tumor spread around the gross tumor, we add another 3 millimeter GTV plus 3 millimeter for clinical target volume. Then liver is moving. So for the motion range, we add another the travel range, the margin. And finally, we set the planning target volume by adding another 3 millimeter to ITB. This is just for to cover up uncertainty or setup error for daily treatment practice. So in external beam radiotherapy, at least gross tumor volume plus 6 or more millimeter margin is added to cover whole area. So it is just enough to cover a microscopic tumor around the main tumor mass. However, in TARE, because it uses beta ray from Y90 decay to zirconium 90, it is very the ideal for tumor control itself. However, due to its short travel distance, usually less than, mean tissue penetration is only 2.5 millimeter. So if tumor is large, and we can expect some microsatellite tumor around the main tumor, then TARE has some chance for failure. Factor number 2 is tumor vasculature. The normal vasculature is follow the growth and development principle by the human development. But for the tumors, tumor cells release vascular endothelial growth factor, and this VEGF trigger the sprouting and budding of the vessel from the main host vessels. And those vessels, tumor vasculature, makes some network, and that consists of a major tumor vasculature. So it looks okay when we see just the growth feature. However, normal vasculature and tumor vasculature are quite different. For example, normal vasculature has a very good, well-structured hierarchy from the vessel, big vessel, larger vessel, and the small capillary, microcapillary vessels. And also in this micro structure, all the thin vessels are well covered with a homogeneous basement membrane, also good pericytic coverage. So even though there's some pressure outside, then still it contain is the caliber, and usually the patency is well maintained. However, in tumor vasculature, because the structure is quite different, usually the end is not well connected together, abruptly ended, and then there's some space that the vasculatures are not well connected together. Because of the reason, all the vascular access treatment has some risk for failure, because why we, although we think that we inject some drugs or the radiation through vessel will distribute very homogeneously, actually there's some risk of this kind of thing. So actually, even for a hypervascular tumor involving hepatocellular carcinoma, tumor always suffering from chronic hypoxia because of that. So in this case, tumor cells are usually lack of the basement membrane and also pericyte detaching. So there are frequent intravasulating of tumor cells, and also due to increasing permeability. Also, when tumor grow further, then these vessels are usually collapsed, because due to lack of basement membrane, it's not easy to keep the caliber persistently. So this is a big difference between normal vasculature and tumor vasculature, which may cause some failure of a vascular approach or the treatment. So in this cartoon, HCC has the good arterial supply, but still there's some very differentiated portion, also capsular invasion, and still persisting portal vein supply, the region in the border. So even though TARE using very small particle size that penetrate inside, but we still see some why we induce some necrosis inside. In the periphery, still there are the portion of the viable tumor that's like this. Then what about the clinical experience? Let me introduce NCCN guideline. This NCCN guideline serves as a major axis for a treatment guideline in a major oncologic community. And for hepatocellular carcinoma, they listed some possible treatment options. Now for the potentially resectable or transplantable, then an unresectable case, even for liver confined inoperable case. Now for the local regional therapy, arterial treatment and the EBRT are listed at the same the efficacy. So researchers thought about that. There's quite the overlapping of indication between two modalities. So there's some attempt to compare efficacy of EBRT and TARE. This is the first study comparing EBRT versus TARE based on the SEER, the database from United States. And among these, the early area, there's a very small number, only 189 patient. And they found that overall survivor and disease-free survivor or the same result between the two modalities. They also analyzed prognostic factors by this forest plot. And although they saw some well-known features as prognostic factors like the stage or a tumor marker or something like that, but for the treatment type, sphere versus beam radiation, they didn't find any significant difference as a prognostic factors. And then there's another study based on the National Cancer Database from United States with a larger cohort with 2,685 patients. And then they compared the oncology outcome between the two modalities. And first, they saw a better overall survival in external beam RT over TARE. However, after propensity score matching, the two modality produced the same overall survival outcome. And then this is our own unit, our institute experience led by Professor To-Young Kim. And this is an analysis based on 209 patients, TARE 65, and liver-directed combined concurrent chemoradiation, 144 patients. If you take a look at entire cohort, then there's more patients allocated in the portal vein thrombosis patients, more allocated in the CCRT. So we did a propensity score matching. So after matching, we can see that all the factors are well balanced between the two the modality groups. Now this is the result. In treatment response, you can see that 3, 6, 1 year, two modalities achieved a fairly good response between 70 to 80%. The quite good result and similar between the two modalities. And for the overall survivor and progression-free survival, a similar outcome was achieved. Then for the prognostic factors, there's already well-known factors like tumor multiplicity and tumor marker, and also PBTT. However, for between tumor modality, TARE and CCRT, it was not that significant prognostic factor. So conclusion was that two modality looked equally effective in treating advanced liver cancer. Now, this patient example I already showed in the beginning. So after we saw this failure, then we thought about to add the external beam radiotherapy to compromise this failure in here. So we did a concurrent chemoradiation, and after this treatment, you can see that the tumor size shrunken, and also intrahepatic mets also the smaller, and the disappearance of lymph node mets. And the tumor marker PIVCA2 decreased from 2679 to 734. However, we also observed occurrence of a new tumor in the left lung. In another case is that when we see unsatisfactory result of EBRT, then additional TARE can be considered. This patient presented a tumor associated with portal vein thrombosis and a very high level of tumor markers. Then we first did a concurrent chemoradiation, and tumor shrunken, also shrunken portal vein, and tumor markers was also decreased. This is just a 1 month follow-up. We can wait further to the follow-up. However, this patient is a Korean American, and he wanted to do all the possible treatment while he should stay in Korea. So his physician prompted to add the tear very soon. So just 1 month later, tear has been added. And after tear, you can see the radiological CR and the tumor marker, the remarkably decreased. And with the further follow-up, and then radiologist interpreted that it's a radiological CR in this MR imaging, and then the tumor markers, all those 2 markers decreased to under the normal range. But this is a very successful case. So there's more concern to combine EBRT plus tear. And this is a Mount Sinai experience for 45 patients. For those patients with a gross vascular invasion, they first observed overall survival advantage. You can see that EBRT plus tear achieved better overall survival compared to EBRT alone. Unfortunately, they used EBRT the modest dose, 30 gray in 10 fractions, very small dose to induce a tumor control. But anyway, the combination result was very successful and very promising result. And more interestingly, when they analyzed the patients for progression-free survival, first, they didn't see any difference between the combination and the single EBRT alone group. However, when they divided patients by the timing of additional tear within 2 months, so patients who received tear within 2 months after EBRT, those patients show significantly higher progression-free survival compared to the counterpart. So they suggested that 2 modalities not separate about so long time, consider tear or EBRT combination, not very soon within 2 months. But this notion needs to be further confirmed by the bigger cohort study. Another report from Mount Sinai is about the safety, because although the combination therapy resulted in good efficacy, safety is always the very important issue. They reported about the 24 patients who received SBRT 40 gray, and then about the tear, range 1 to 3, median number 1, plus minus taste. They observed some decline in liver function, like the CTP score change and the RV score change. However, there is no detrimental toxicity, and they concluded that combination seems to be mostly acceptable in toxicity, and but still we need to see the further result, because this study only reported in the abstract. The paper has been reported yet. And finally, this is the study reported by a Taiwan group, and then they analyzed those volume histogram of normal liver receiving radiation from both modality, SBRT and tear. And they divided the patient without toxicity and with toxicity. So this is dose volume histogram. Then you can see that the area on the curve means that the dose of radiation that was received by the liver. So in this the figure, I don't see any big difference between two, but you need to check that the scale is quite different here in x-axis. So I modify this figure as a realistic scale. So this is patients without toxicity. This is a patients with toxicity with the same scale. And you can see that patients without toxicity, this area on the curve means the radiation, integral dose of radiation given to liver. Then in this figure B, patients with toxicity had a very large volume of liver receiving high dose radiation. Some patients received radiation dose up to 600 or more. So the paper suggests that DVH, dose volume histogram for the individual patient, is very important to identify patients who will eventually develop toxicity or will not develop toxicity. So to conclude, A combination of TARE and EBRT seems beneficial in selected patients, but the safety seems acceptable, but needs further study because there are only few studies to claim the safety for this combination. Thank you for your attention.
Thank you. Thank you, Professor Song, for a nice and excellent lecture. So this is time for a discussion. So we already have some questions from the audience. The first question is, what would be the most optimal interval from EBRT after initial TRE?
Actually, there's not many reference to answer to the question, but in my experience, EBRT usually induce tumor response in the later time. So best time for observing response after EBRT is between 6 months to 8 or 10 months. So I think we need to wait more. And then another advantage of waiting more is that EBRT may have some liver function decrease very transiently. So we need some time to recover from that transient the liver function detriment. So my answer is that maybe 6 months, but we need to gather some data for to suggest that answer.
Yeah, Professor, for your presentation, we learned that adding EBRT can be an option to improve TRE outcome, but I think there will be not to all patients for a selected patients. So in your opinion, who are the optimal candidate to combine EBRT to TRE?
Actually, for the patients who are associated with major portal vein thrombosis, I don't think TRE seems still very capable of or control the portal vein tumor thrombosis. So in case if TARE can control major the primary tumor, maybe EBRT can control the vascular invasive area, or vice versa will be possible because sometimes EBRT fail in some area and TARE can be complementary to enhance all the tumor response together.
Professor Song, thank you for the excellent lectures. I have one question, and how to calculate the total dose, total tumor dose of combined treatment patients. How to calculate the dose, externally delivered dose and internally delivered dose.
Well, for EBRT radiation dose dosimetry, we have the very well-designed dosimetry calculation software system. So it's our daily practice, daily routine, the procedure. But if we need to combine EBRT dosimetry and TARE dosimetry together, maybe we need to discuss with the interventional radiology specialist to combine their software with our software together. It is our daily practice.
It is larger than the simply adding the both calculation value, or is quite different from the simply adding both those.
Oh, that's a good question. Because radiation, external beam radiation deliver radiation dose just very high dose to the tumor and the surrounding area, and lesser dose by the distance from the primary tumor. And I think the principle will be applied to internal radiotherapy, TRE. So I think the principle will be the same. So only thing is that EBRT, we calculated dose to the liver by biologically equivalent dose concept. But I think we need to apply the same concept to internal beam radiotherapy because they deliver with high dose radiation at once. But in our case, we deliver radiation not at once. We do sometimes 25 fractions, sometimes 4 fractions, sometimes 10 fractions. So depending on the fraction number, we have a different calculation method. So it's not easy to answer very simply here. So yes.
Thank you. Okay, now thank you for the discussions. And now we are moving to the next lectures. The topic is tear combination of tear with TKIs, and presented by Professor San-Chi Chen from Taipei Veterans General Hospital. He is oncologist, and he's working in Division of Medical Oncology in Taipei Veterans General Hospital, Taipei. Dr. Chen, please.
Oh, hello. Thank you for your invitation, and I'm sharing my screen. Do you hear my sound and the image?
Yes, we
Okay.
can hear you.
Okay, thank you very much. Oh, today, my talk is about tear with TKI. I'm San-Chi Chen.
But the screen is too small. Can you enlarge the screen?
Let me check. Oops. Sorry. When I test, it is okay. I'm sorry. Oops. I stop the sharing and do it again.
Yes, it seems good.
Professor, your microphone is off.
Hi. Okay. Is it okay right now?
Yes,
it's
Yeah,
good.
I'm sorry for that. I'm a medical oncologist, and my major of my patient is liver cancer and sarcoma, and also the other GI cancer, lung cancer is I also treat the patient as well. So today my talk is to talk about the tear and the TKI. As we know, the TKI recently, due to the development of immunotherapy, most of the TKI actually it called multiple kinase inhibitors, and okay, we say TKI is okay. They have immune modulation effect. This is a review paper from Professor Zhang Anli. So the different TKI has different immune modulation effect to different kind of immune cells. It's complicated, and most of the people believe that they have immune modulation effect that if we combine with the TKI and the immunotherapy, they may enhance the anti-tumor response. Also, EH90 is also reported to have an immune modulation effect. Dr. Chu reported with the Pierce Cho, their study team, they found that EH90 has an immune effect when we monitor the peripheral blood, and the immune effect may last for about 3 to 6 months as long. The other study group also showed that the immune modulation effect of the EH90, the peak effect is about 1 month, and that will decline gradually to 6 months. So although the time point is different, but both of them show the immune modulation effect of the radioembolization. So today my outline is to talk about the combination of radiotherapy and TKI, and also the tear versus TKI, and the tear versus plus TKI. So this is a study because tear is also kind of internal radiation. So I researched the data for the combination or the comparison of the sorafenib and the radiation. This retrospective study includes BCLC, BC, HCC patient, exclude metastasis patient, and divide into two arms. The patient number is like this. So one arm is radiation alone, and one arm is a concurrent sorafenib and the radiation. On the toxicity, the radiation-induced liver toxicity is not different between the radiation alone and the concurrent group. And the GI bleeding risk is also similar. So there are no significant difference about the toxicity. And the progression-free survival between the two arms is not significant different. So subgroup analysis show that most of the subgroup, we cannot see any predictor factor among the group. So the effect is almost similar between the two groups. And the overall survival before matching and after matching, the result is similar. So from this study, no survival benefit with the concurrent use of sorafenib and the radiotherapy in locally advanced HCC. Because the report is limited, so I found some case report with the lenvatinib combined radiation for a potovan thrombosis positive HCC patient. This patient treated lenvatinib previously, then to use the radiation therapy for his potovan thrombosis. We can see the thrombosis here, and after radiation, the base potovan is pattern. So the tumor marker is decline rapidly after radiation. So this is a successful case for the combination of TKI and the radiation. The other case report show the lenvatinib combined IO with radiation. This is also a case report. This patient has very severe thrombosis. The tumor is tend to SVC and to the right entrance. You can see the tumor thrombosis is so huge. After combination of lenva and the IO, the tumor, the thrombosis regression to small size after radiation therapy. So this is also a successful treatment for this very advanced and poor outcome patient. However, from the current report, we found that it seems there is no synergistic effect found by TKI combined radiation. However, selected eligible patient for the combination, we can both control the systemic disease and also the very locally advanced disease. So the move to the second part, the TARE versus TKI. As I believe all of you know that there are two randomized phase 3 studies to compare the sorafenib and the ETRM-90. Both the data has reported and show that the survival benefits not different from both treatment. So the first is SARA study and the second is the SERNIP study. Well, so we can, this study raised by Pierce Cho, and we can see the tumor control, tumor response is higher in the radioembolization case. The response rate is over 15% rather than sorafenib. And the disease control rate is similar in both groups. But the higher response rate did not lead to better overall survival. We can see, although not significant different, however, sorafenib still has longer median overall survival, but the progression survival is similar. So this study concludes that the overall survival is not different between the both groups. About the toxicity, the sorafenib group has more GI toxicity and the skin toxicity. Those were familiar, we know, related, induced by sorafenib. The second randomized phase 3 study is SARA study. they enrolled BP4 patient about 1/3 of the patient, and randomized to the third and the sorafenib. We can see similar, the sorafenib has a little bit longer overall survival, but not significant, and the overall progression-free survival is similar. They analyze why the progression and the survival from the two groups. We can see the time to progression is higher in sorafenib group. That means the sorafenib tend to have earlier progression. However, the survival is better in sorafenib arm. And if you see into the subgroup, we can find the intraliver progression is earlier in sorafenib group, but the extraliver progression is slower in sorafenib group. Maybe this is why they come to the result that sorafenib group has longer survival and later cancer death. So the response is also similar to the previous study. The response rate is higher in third group. And the subgroup analysis also showed all of the group favors sorafenib. So this study concludes that although HN90 achieved better tumor control, higher response rate, but maybe the extrahepatic control is inferior. So lead to the survival somehow a little bit lower than the sorafenib group. And the quality of life is better in third group, but not sorafenib. The other two study is retrospective study. The first one used a propensity score matching to compare the HN90 to sorafenib. So they enrolled the BCLC B and C patient, and the patient number is about 6 to 70 patients. We can see the progression-free survival from the two group is also similar. The median of the sorafenib group is a little bit longer, and the overall survival is also similar. So from this study, in the intermediate advanced HCC, the both treatment is showed a similar efficacy. However, only patient treated with TARE may downstaging and can follow the liver transplantation. So there is no such case in sorafenib group. And the last part is the TARE plus TKI. If the treatment efficacy is similar, how about to combine them? So from the previous report, we can find that the TARE showed very good local control efficacy, and the TKI can systemically control the disease. So if we combine with the two treatment modality, maybe we can make the patient live longer. So this study is a retrospective study, and only 8 and 6 patients in both arms. So to compare with the HN90 with or without sorafenib. In the group, the HN plus sorafenib, the biomarker showed the angiotensin 2 and the PDGF, the two kind of factors decrease after sorafenib treatment. We know that the two of the markers is related to the angiogenesis. So the combination of the HN90 to sorafenib may inhibit the angiogenesis, maybe have beneficial to the tumor control. The other study only have 29 patients. They use the sorafenib treatment initially, then followed by HN90 plus sorafenib. And this is a single arm retrospective study. The overall response rate is about 30%, and but they found the responder tend to have smaller tumor the diameter is about less than 5 centimeters. Those patients with the treatment strategy without response tend to have larger tumor size. So I think it's very reasonable. And the median overall survival in this cohort, the median survival is about 1 year. That is similar to we know the survival for the advanced HCC. So the preliminary data from this cohort, they showed the safety and the tolerability is well. The toxicity profile is like here, and the efficacy is modest. So maybe this is a reasonable potentially combination for HCC. This is another group. They have more than 100 patients, but they divide patients to the different treatment arm according to their tumor burden. If the tumor, intrahepatic tumor, is less than half of the liver volume, they treat the tear only. If the tumor has aggressive disease features or larger than half of the liver, they treat the tear combined sorafenib. Just like that, we can see the overall survival is higher in the tear alone group because this patient has limited HCC, and in the combination group, the survival is lower because the advanced stage. So in the tear alone, this group, alpha protein level more than 400 is a poor prognosis, lower survival. And in this group, the bilobar, the tumor distribution has poor prognosis. So in this cohort, tumor volume less than half, these two are risk factors for the patient. In the combination group, of course, patient with a liver tumor more than half of the liver volume is a poor prognosis factor, and also the alpha protein level more than 400. The same, you can see the same study group that extend more patient, a little bit more patient. They report another paper. In this paper, they show the response. They was not report in the previous one. And the response rate is around 30 to 40% of response rate. And the time to progression overall, of course, the tear alone, this group has limited tumor. The time to progression is longer. And the combination, due to they have advanced stage, the time to progression period is shorter. So in their study, they conclude that this combination, based on the tumor status, provide the control rate 70% is quite well. However, the extrahepatic progression is more common in the high disease burden group. So I think their data show the preliminary to combine this SORA and the E390, but cannot make very strong conclusion to clinical use. The other study from Italy, they show the you can look carefully. This is combined Yttrium to sorafenib versus sorafenib using a propensity score matrix. In this study, the patient number is 45 and 90 patients in the two groups. Even the combination not show the longer progression-free survival and not overall survival as well. So far, the combination of E390 and SORA did not offer longer survival benefit. And the response rate is quite similar, and the toxicity profile like this. So they conclude that the addition of sorafenib, addition of E390 to sorafenib patient did not prolong survival. This is another study also to combine SORA. Okay, it's a little bit different. It's similar. Sorafenib combined E390 versus sorafenib. the patient number is 73 and 100 patients. So this is only positive study for the combination. The response rate is higher, 50%, more than 30% in the sorafenib group. The p-value is significant. And the factors associated with updated response, the general characteristic is cannot predict how only the combination group. This factor is only one significant to predict better objective response. And they showed the combination group has the median survival reach 15 months, longer than 13 months in the sorafenib group, although the statistically not significant. However, it shows a trend for us. So this is only one positive study show that the combination has longer overall response rate and the progression survival, but the survival benefit is not significantly different. Okay, I show two case reports. One is my patient used TKI plus radiotherapy. The thrombosis extend to the right atrium. After the TKI and the local therapy radiation, the thrombosis showed regression, and he continued the TKI use. My better experience for the combination of systemic therapy to the E19 is have to combine immunotherapy. I know the future will introduce IO plus E19 later. So this is a patient with very advanced tumor, very high large tumor. He used the E19 first, then combine atezo-beva later. You can see, and after due to very good response, he do the right lobectomy for his tumor. So you can see the initial tumor is very big, and after E19 show the central necrosis, and they'll combine atezo-beva and the TACE again. The tumor necrosis completely. Then after he underwent lobectomy and provide he very long stable disease without recurrence, and the tumor marker decline very rapidly after the treatment. So my take-home message: radioembolization therapy is indicative and very powerful for local control, and sorafenib or other TKI is for systemic control. The synergistic effect of E19 plus TKI was not found in the current study and current evidence. So how to select eligible cases for adequate treatment to combine the systemic therapy and the local therapy is recommended. Okay, so this is my talk today. Thank you very much.
Thank you, Professor Chen. And now this topic is open to the question from the audience. And we have one question. What do you think the use of personalized dosimetry would change outcomes of TAIR plus TKI?
You say what factors would impact the benefit, right? I think because the traditional, we can see my research, my literature review show most of the data is from the sorafenib. We know that sorafenib only tumor control rather than response. Maybe in the future, the lenvatinib, that is a targeted therapy, provide more higher response rate and longer progression-free survival, about 7 months. Maybe to combine lenvatinib to E19 may offer more clinical benefit for the patient because the better systemic control and the very powerful local control. So I'm looking forward to that. Maybe in the future we can have the data.
Okay, Professor Sen, thank you for the nice lectures. And we somewhat running shortage of time. So now we are moving to the next topics.
Okay,
and
thank you very much.
Next topic is combination treatment with immunotherapy, TAIR combination with immunotherapy. And the presenter is Dr. Pierce K. Chow, who is a friend of mine for a long time, and he's now the professor and program director of Duke News Medical Center and senior consultant and National Cancer Center Singapore. And he is doing multi-center clinical trial as protocol chair, including Sorobinib study and many big studies. It is my great pleasure to have Pierce Chow in this webinar. Pierce Chow, please.
Yes, thank you very much. May I share my screen? Are you able to see my screen?
Yes, we can see.
Thank you very much. Yeah. Yes, good afternoon, everyone. It's a pleasure to be here at the Korea Radioembolization Society. And I would like to thank my old friend, Professor Kim, and members of the organizing committee for inviting me to speak. My name is Pierce Chow. I am a senior consultant surgeon at the National Cancer Center Singapore and the Singapore General Hospital, and professor and program director at the Duke NUS Medical School. The title of my talk today is Transarterial Radioembolization with Immunotherapy. And what I'll do is that I will review the current evidence and also discuss the future directions of this interesting combination. These are my usual disclosures. As you know, hepatocellular carcinoma has the highest prevalence in Asia because of our high prevalence of chronic hepatitis B. But HCC is also a very significant public health problem globally because of the very high incidence to mortality ratio of 0.98, which is the highest for any solid tumor. And that is also because there's absence of predictive biomarkers and therefore very poorly efficacious systemic therapies. And today we still don't have a proven adjuvant therapy. At the time of diagnosis, about 22.3% of HCC are diagnosed at the early stage. Another 46% are diagnosed with a locally advanced disease, of which about 24% are in intermediate HCC, and another 22% have vascular invasion, and a final 31.7% are diagnosed with metastatic disease. The stage at which the patient is diagnosed is very important because that determines the therapeutic aims in HCC. If a patient were to be diagnosed with early stage HCC, then the therapeutic aim would be to achieve a cure for this patient, either through liver resection, transplantation, or ablation. But if a patient were to be diagnosed with locally advanced HCC, then the therapeutic aim is to downstage the patient so that the patient can receive curative treatment, and failing that, to try to prolong and improve the quality of life. But if a patient is diagnosed with metastatic disease, then the aim is to prolong and improve the quality of life. As you know, local regional therapy is currently the standard of care for unresectable locally advanced HCC, and of which there are two main modalities: transarterial chemoembolization and also selective internal radiation therapy, which is also known as radioembolization with Yttrium-90. As all of you are already very familiar with both modalities, I will not describe them further. But you will know that in March last year, the FDA has approved the use of Yttrium-90 microspheres as monotherapy in solitary HCC of less than 8 cm with preserved liver function. And that is on the basis of the very good results of the legacy study, where the primary outcome was tumor response. And what you can see is an excellent tumor best overall tumor response of 83%, bridging the resection of 6.8%, bridging the transplantation of 2.1%, and as primary tumor in 72.2% of the patients. So the use of radioembolization in HCC is currently established, but the important question that we ask ourselves is the biology of HCC actually changed after radioembolization? We ask this because the half-life of Yttrium-90 is very short, it's 64.2 hours, only about 2.67 days. But those of us that use radioembolization will know that the therapeutic effect is very sustained, 3 months, 6 months, and sometimes 9 months. And the very minimal adverse events seen with radioembolization together with a prolonged response suggests that radioembolization on top of the radiation effects may also initiate an immunological response, and this persists beyond the half-life of the radionuclide. So that was a very important hypothesis, and that hypothesis was put to the test in a prospective study carried out at the National Cancer Center Singapore, where we were able to collect peripheral blood from the patients before and after Y90 radioembolization. And for those patients who were downstage to resection, of course, we have access to the tissues, and we were able to do RNA sequencing to look at the TILs and compare that to surgical resection of patients without prior radioembolization. And the immune profiling was done using time of flight mass cytometry, where we look at 41 parameters altogether. And what we have seen was a very interesting results. These are example of patients before and after Y90. So in the patients that were downstage to resection, we were able to have access to the tissues, and what we found was an increased local cytotoxic immune cells after radioembolization. We saw an increase in natural killer cells, or natural killer T cells, CD8 positive T cells, and CD4 positive T cells. And this increase in cells were not seen in the controls, where the T cells were mainly regulatory. And when we sequenced the HCC, we saw upregulation of multiple activating pro-inflammatory immune genes in the post-Y90 tumors, and these were again not seen in the controls. And looking at the peripheral blood, we also see systemic immune upregulation pre versus post-Y90. At 1 month, we see increased TNF alpha expression in the CD8 positive TIM3 cells, and also in the CD4 positive T cells. And at 3 months, we saw increased proportions of CD14 positive HLA DR positive APCs. And using functional annotation of Y90 enriched genes, we found that the CD8 positive T cells migrate to the tumors upon treatment with Y90. So it seems that the tumor microenvironment in HCC is significantly altered after radioembolization, with very significant immune modulation, and this explains the very good results. So this study was published in the journal Gut in 2018, and as Dr. Chen has mentioned, we were very pleased earlier this year when results in their study, which they published as a letter in the T cells and inflammatory monocyte populations. And they found that these immunomodulatory effects peaked at 1 month after Y90.
We cannot hear because the line is poor. 다시 한번 연결해 보면 될까요?
So we are having trouble in internet connection, so please wait for a minute. So we are contacting the professor again.
어떻게 해야 될까요? 끊었다가 연결해야 될까요? 아니면은 이게 좋아질 게 없어 보이는데 로그아웃 됐네요. 다시 연결하시겠네요. 음. Please wait a minute. We are trying to connect again.
Hi, everyone. So sorry, it seems that I lost connection.
Mhm.
Yeah,
Yeah.
I'll continue where I ended. Can I share screen again? Yeah, I think I lost everyone at around here. Were you able to
No, please, previous.
previous? Okay, that's great. Thanks. Yeah. This one is okay?
Previous. Yes, this one.
Yeah, right. Yeah, so apologies, everyone. I got offline. So from our previous study, we also found evidence of systemic immune upregulation in pre versus post Y90 PBMC. So at 1 month, we see an increase in the TNF alpha expression in CD8 positive TIM3 cells and also in CD4 positive T cells. And at 3 months, we also increase a proportion of CD14 positive HLA DR positive APCs. And when we accessed the resected tissues and did the RNA sequencing, we found that in those tumors previously treated with Y90, there was a significant upregulation of multiple activating pro-inflammatory immune genes in these tumors. And this was not seen in the control tumors. And also we saw that when we look at the functional annotation of the Y90 enriched genes, we saw that the CD8 positive T cells actually migrate to the tumor upon treatment with radioembolization. So this very interesting data showed the tumor environment was changed with the Y90, and we published that in Gut in 2018. And we are very pleased this year, as earlier suggested by Dr. Chen, when we found that Professor Masafero and his group in Milan also found the same results with the Y90, where they found that Y90 induces immune response in HCC with increased frequency of activated T cells and inflammatory monocyte populations. And this peaked at 1 month, and they suggested that the timely delivery of immune checkpoint inhibitors may enhance the immunological anti-tumor response to radioembolization. And they published this in a letter in the same journal Gut earlier this year. But of course, as you know, there are 2 modalities of local regional therapy. There is TACE and there is also radioembolization, and which is actually more immunogenic, because local regional therapy have the potential to act synergistically with immunotherapy. So to address this question, this group from Europe carried out the study to compare intratumor immune infiltrates in resected HCC after preoperative treatment with either TACE or radioembolization. And they looked at TILs, CD4 cells, CD8 cells, and also granzyme B expression. They compared 32 surgical patients with resection and no prior therapy with 16 patients Yeah, my apologies again. I think, are you all able to hear me now?
Yes, and TACE versus TARE in immunology term.
Yes, that's right. So what this group has found was that in the radioembolization treated HCC, CD3 positive TILs, CD4 positive T cells, and CD8 positive cells, and also coenzyme B expression was significantly increased, and this was not seen in the others. And they concluded that radioembolization, but not TACE, significantly improve intratumor infiltrates. And of course, this is very much also related to the current efficacy or performance of systemic therapy. So for a long time, we only had sorafenib, and lately we have lenvatinib. But in the year 2000, because of the IMbrave150 trial, we had atezolizumab and bevacizumab, and this was superior. It delivered a median overall survival of 19.2 months in the patients. And if you look at the trial, it was an important trial because it included patients with very high tumor burden and also patients with vascular invasion. And if you count down on the overall response, you can see that the overall response of this immunotherapy combination, A plus B, is at 30%, is significantly better than sorafenib at 11%. But what it means also that if you use the best systemic therapy today, you would expect that to see response in only 1 out of 3 patients. And of course, earlier this year, the Himalaya study was also presented. And this is a very complex 4-arm study, but we are interested mainly in arm 3 and arm 4. Arm 3 is tremi plus duva, and arm 4 is the active comparator sorafenib. And here again, you can see that the STRAT regimen using tremi and duva is better than sorafenib, 16.4 versus 13.8 months. And if you look at the response of the STRAT regimen at 20.1% is significantly better than 5.1% in sorafenib. But what it means also is that if you use the regimen, only about 1 in 5 patients will respond. And this poor response with immunotherapy is very much related to the immune phenotypes in HCC. As you know, about 30% of HCC really don't have any T cells inside the tumor. And our current immunotherapy that requires T cells will not be expected to work. And in another 25%, of course, these are the immune excluded phenotype, where the T cells are all at the surface or at the outside of the tumor and doesn't get in. And here also your current immunotherapy that requires T cells will not work. And in fact, the current immunotherapy will only work in the last 45% of the patients where there are T cells inside. So the difference that radioembolization makes is that it increases CD8 positive T cells across the HCC. And today there have been 2 open label single arm phase 2 studies of Cersphere followed by immunotherapy with nivolumab. The first is a study published in Lancet Gastro and Hepato last year. And the second is a study published in the Journal of Immunotherapy in Cancer this year, but was first presented 2 years ago in 2020. So the first study was a Spanish study called the NASA HCC. And the second was the study from the National Cancer Center, Singapore. And while the 2 studies look very similar, they're actually very different. The NASA HCC study enrolled 42 patients from multiple centers in Spain, and they do not include patients with extrahepatic disease, while the one from NCC Singapore included about 36.1% with extrahepatic disease. So in fact, the 2 studies are quite different. And in the NASA HCC study, the response rate was 40%. In the NCC study, it was 30.6, but if you exclude those with extrahepatic spread, it is 43.5. 40% and 43.5% are very significantly better than the previously known response rate of nivolumab, which is only 15%. So currently, there are 3 randomized controlled trials combining radioembolization with immunotherapy in HCC. The first is the trial that was recently launched at the National Cancer Center, Singapore, that will enroll 176 patients, enrolling very high volume patients in one arm, Cersphere, followed by atezolizumab and bevacizumab, and in the other arm, Cersphere, followed by placebo. The second study is an industry study sponsored by Boston Scientific. In one arm, there is Therasphere alone, and the other arm, Therasphere plus the STRAT regimen of tremi and duva. But this trial excludes vascular invasion. The third is the investigator-initiated study by Hanover Medical School, where one arm will have radioembolization plus tremi and duva, and the other one will be TACE followed by tremi and duva. And this is a cone down on the recently launched study at the National Cancer Center, Singapore, where we enroll patients beyond the up to 7 criteria, patients with larger tumors and with vascular invasion. Delivery of Y90 can be single or double stage, after which they are randomized to receive either the atezo and bevacizumab combination or placebo. The primary endpoints will be best overall response rate at 12 months post-randomization. So this is a study that will be done in 4 countries and in about 170 patients from about 13 sites in the region. Thank you very much for your attention. Very sorry for the interruptions to the internet. I'll be happy to take any questions.
Okay. Okay. Thank you, Dr. Chow, for the nice and excellent lectures. And we have one questions from the audience. Did you see the level of regulation of T cells associated with those?
In our study, we have not correlated that with those, but as you know, worldwide, among users of radioembolization, there has been a trend to increase the radiation dose. So at the National Cancer Center Singapore, many of our nuclear medicine colleagues are going to doses as high as 200 grays today. And obviously, in many studies recently published, there is a suggestion that the higher the dose, the better the response will be. But of course, in exchange for the higher dose, you may potentially also get more AEs, although that has not been really documented.
Okay, I have one question. Pierce, what do you think is the best interval from the radiation treatment with and between radiation treatment and IO treatment in terms of from the viewpoint of immunologic aspect?
Yeah, I think both our study and Professor Macefero's study also agree that the peak actually arises in about 1 month, about 4 weeks. And thereafter, it will tail down. So in the Macefero's study, it tails down very abruptly. In ours, it tails down a bit more slowly, but I think the doses used may be different. So I think both groups will agree that giving the immunotherapy at about 1 month may be the best time to give it, and also allows an interval between the 2 treatments so that the AEs will not overlap. So in the 2 phase 2 studies, 2 single-arm phase 2 studies, they were all both given at about 1 month based on the earlier publication. So 1 month seems to be the best time to give it.
Okay, thank you.
Professor Cho, I have just one question. The immunotherapy combination is very costly. So what do you think we need to schedule combination with TRE altogether? Or is only one immunotherapy drug will be enough to combine with the TRE? So what's your opinion?
I think from the patient point of view and the doctor's point of view, I think the best is actually to combine both, because as we all agree, radioembolization gives you very, very good local control. And the failure in radioembolization is always the appearance of new tumor, either outside of the liver or in the contralateral lobe. So essentially, to maximize the ability to control the tumor, we should add the systemic therapy to radioembolization. The question has always been, what should we add? Of course, TKI has been added. The results are not very impressive. So we hope that because of the innate ability of radiation to cause immunomodulation, perhaps the addition of immunotherapy will be much better than the addition of TKI. So from the point of the patient, of course, the best survival is the better. I think cost is a factor of science. As all this becomes a standard of care, then all the governments in the world will have a lot of leveraging on the pharmaceutical companies because of purchase in bulk, and I think because of ethics, the cost of therapy will definitely drop. It's also the same as what we see with all the other targeted therapies. The costs have dropped because of the increased use and because of the ethical issues about high cost. So I think as doctors, we focus on the science. Then if the science is good, we hope that we can afford the therapy for everybody. Yeah.
Again, the combination is very expensive. So what can be the biomarker for the best responder of combination treatment?
At the moment, from our earlier studies, we have fairly good idea of what the biomarkers are, but in fact, what we will do is that we will be testing out these biomarkers in our current clinical trial to see that in the future, whether we can predict patients that will respond. Of course, one of the weaknesses of HCC today is that HCC, among all the common cancers, we are the only cancer that has no predictive biomarker. So the ability to get a biomarker will be very important, and we only give very expensive treatment to a smaller group of patients that will definitely benefit rather than giving it to everybody. So this will also be studied in our current study that we have just launched, and perhaps we can have the answer at the end of the study, hopefully, yeah.
Okay, thank you. So, now I'd like to close these sessions, and thank you very much for the distinguished lecturers and all the participants who are actively involved in these hot topics. And I hope all of you enjoyed our webinars, and thank you very much. And Merry Christmas and Happy New Year. Thank you.
Thank you. Merry Christmas. Yeah.
Thank you. Merry Christmas.